Today, our webinar is about improving clinical care in VCP disease. I had the honor of working with Dr. Korb as the study leader and a group of very dedicated clinicians to produce this. A few statistics on the project. We had 10, oh wait, is it advancing?
You need to switch to the presentation mode, actually.
Oh, it's not in the presentation mode?
And the
Oh, okay, hold on. Okay.
Yeah,
You should have told me before, Manisha.
I had to say something and
Okay, all right.
Her hands were going.
Were they? Okay. I even practiced this with Nathan beforehand. Okay. All right, how is that?
that's better.
Okay, good. All right. So a few statistics on the project. We had 10 working groups, 50 experts, 30 institutes, 8 countries, and it took 14 months from project concept to publication, which is unheard of. And we had one mission, which is for patients to be able to walk into any clinic anywhere and get the same, have access to quality care. And so we've mailed some of these business cards to people, and if you scan it, it pulls up the publication. We didn't do this alone. This is the list of our collaborators. It was just truly an honor to have to work with all these experts coming together, lending their talents, and I was in awe at what the power of people working together can produce. Did it get off again? No. Okay, there we go. Okay, so I was going to share the story a little bit, what the need was. It started with, or it sort of started when Nathan was having trouble with his hand. It was in pain. We didn't know what it was. And so we went to his annual neurology visit, and we said, well, he's having bone pain and there's a little bit of bone deformity. We kind of think that we need to make sure and rule out Paget's disease of the bone. And the doctor just kind of looked at us and he said, I need a publication for that. I'm not just going to prescribe a nuclear bone scan. And we were kind of taken aback. But then we thought about it. One of the rare disease truths that probably patients encounter all the time, and doctors, there's over 10,000 rare disease, and it's impossible for all doctors to know how to treat all of them. And rare disease is so complicated. And VCP disease is especially complicated. It's ultra rare and affects multi-body systems, the muscles, the bones, the nervous system. So it requires doctors to kind of go outside of what their specialty areas, and you need a team of doctors. So it's hard to diagnose something that's a little bit out of your specialty. And so the concept came from me going to our medical advisors and saying, hey, can you give us a publication that tells our doctor what we need to do? You've told us what we need to do, but now I need to tell my doctor. And he goes, well, I can't do that. Well, what? And he said, well, because I can't tell another doctor, that just puts me in a weird position. I don't necessarily know. I need a team of doctors from a lot of different areas coming to develop the best possible. I have my own perspective, but that doesn't mean it's the best. So I kind of, the other truth from that I didn't see as a patient, but from a doctor's point of view, even as experts, it's very tricky for doctors to tell other doctors what they should do, unless there's scientific evidence and published manuscripts to prove otherwise. As patients, I know from being in my position that each of you, your stories are kind of similar. So what we decided to do is said, let's do a Zoom meeting, a 3-hour Zoom meeting, and we'll all get together and we'll brainstorm and we'll develop this care guidelines. It ended up being a little bit more complicated than that. And thankfully, Dr. Korb stepped up to help manage the project with me. But it involved all the teams, researching all the journals, bringing their personal experience, working groups, discussions, surveys. But the result was a global and accessible peer-reviewed guideline. And it didn't happen on its own. Patients and patient perspective was so important. You and your doctors are in partnership, and they need you to tell them about all of your symptoms. So it's all this, I've said this again, this project is because patients and doctors are sharing their time and experience. Part of this was integrating the patient's experience into the project scope. And the way I did this, I kind of gathered what I know from talking to the different patients. And in all of our discussions and happy hours and Facebook posts, and I kind of came up with a list. This is just some of them. I was first misdiagnosed as something else. It took me 7 years from going to doctor before I was diagnosed as something. I'm my doctor's only patients, and the list goes on and on. And so we took those experiences that patients had, and we created a project scope. The gaps were the disease is under-recognized, especially in the neurology setting, delays in time to diagnosis, no care guidelines existed, and the timing of the referrals to other specialists was not defined. This resulted in a prolonged time to treatment, delay in recognizing involvement of other organ systems, different care between different clinics, and the disease being underdiagnosed at risk. And so this kind of talks more about the patient-doctor partnership and how it'll improve your health journey. And this is kind of new. We developed it. It's not in print yet, but we're going to be bringing it to the patient registry. It is one sheet to take to your doctor. It has a list of all the different potential people in your care team. And then it also lists all the different symptoms that you need to be aware of and talk to your care team about. Before we get started, I did want to point out on the business card, there's a lot of different names there. And so why so many different names? The old name is inclusion body myopathy associated with Paget's disease of bone and frontotemporal dementia. And the reason why we still hold that, the reason why we still have that, is it's tied to a lot of historical publications, and it's in rare disease databases such as the OMIM, which is a big database of all the genetic diseases. We call it VCP disease. That's kind of the layman's term. The new name for it is Vallicin containing protein associated multisystem proteinopathy. And so when Dr. Korb goes through her presentation, she's going to be referring to what we say VCP disease. We're going to be calling it VCP MSP for short. With that, I'm going to hand it over to Dr. Korb, who's an assistant professor at the University of California, Irvine. Manisha?
Yeah, thanks so much, Allison, and thank you everyone for being here tonight. It's an honor to be giving this webinar to you guys for Cure VCP. As I said, I'm broadcasting from UC Irvine, which is about an hour south of LA. And I wish I could be there in St. Louis, but won't be able to make it. So I'll try to share with you all my knowledge tonight. Okay, so next slide.
Manisha, if you could get a little closer to the mic.
Oh, I might have to use this.
That's much better.
Okay, sorry. This is a dictation device. All right. So this slide here will give you an overview of all the different phenotypes or disease presentations that we can see with VCP MSP. And another disclaimer is that although we're saying VCP MSP, there are several other mutations that can cause multisystem proteinopathy with the same sort of clinical presentations, which we'll get into in a little bit. But ultimately, we'll refer to them all as VCP MSP today. This table pasted here is taken from the paper that we published last year. That was a culmination of all of our expert opinions and our meetings over the last year and a half. And it kind of gives you an overview of the different clinical presentations or phenotypes that you can see with VCP MSP. I'm going to talk about each of these different sections in a lot more detail throughout tonight's presentation. But a couple of the ones that you're not going to see me talk about are Alzheimer's disease, which most of you are familiar with, is a dementia with predominantly memory loss. This occurs in about 2% of VCP patients. And spastic paraplegia is the other one I won't be mentioning tonight. This one has been seen only in isolated cases, and it presents with leg weakness and spasticity, so kind of rigid tone of the legs and increased reflexes in the legs. So those ones we won't be mentioning, but they're in this table here. And then the picture on the right is also a really great diagram that shows you how pervasive VCP mutations can be and how it really affects so many different organ systems in the body throughout the torso, as well as the musculoskeletal system and the central nervous system and peripheral nervous system as well. Next slide. Okay, so to sort of give you an overview of what today's slides will look like, we'll first talk about the clinical features of each of the different phenotypes, including the frequency of how often you'll see that phenotype in VCP MSP patients, and we'll talk about the symptoms and physical appearance. Then we'll talk about different diagnostic tests that are used, including blood tests, imaging, and other procedures to be able to make the diagnosis of that phenotype. In terms of management, we'll talk about different therapies, supportive therapies, medications, procedures, assisted devices, and even surgeries that are used to help manage and treat the symptoms for the different phenotypes and help improve quality of life and functioning. We'll also talk about surveillance, starting with what baseline tests should be done at the time of diagnosis. Say someone has a diagnosis of VCP MSP, but they only have myopathy. So how do you screen for FTD, or how do you screen for ALS and other things? And how do you screen for those along the way over the years as well? So tonight's key features, I think it's cut off at the bottom, basically we'll talk about genetics, myopathy, frontotemporal dementia or FTD, Paget's disease of the bone, ALS, Charcot-Marie-Tooth neuropathy, Parkinson's disease and Parkinsonism, cardiomyopathy, respiratory dysfunction, urinary and anal incontinence, supplements and nutrition, exercise, and at the bottom it should say mental health, but I don't think you can see it, or at least I can't see it. And then the goals of tonight's presentation and the project and the paper that we made were to increase awareness of VCP MSP, improve time to an accurate diagnosis, and establish a multidisciplinary standard of care for the different diagnostic testing and therapies for managing the different subtypes of VCP MSP. Next slide. So,
All right, it's not there.
okay, there we go. So we'll talk about the genetics of the condition first. As they mentioned during the live stream portion earlier tonight, genetic testing is the only conclusive and definitive way to diagnose VCP MSP. There are many other tests that you can do for the different subtypes, but those will just be supportive and not definitive. So in order to qualify for genetic testing, a person should either have a personal or family history of one or more of the phenotypes. So for example, a patient could have myopathy and bone disease in themselves, or they may have a family member with FTD or a family member with ALS and themselves have a different phenotype. And in those cases, that should clue the doctor in to test for VCP. And also mentioned in the live stream today in the video, it's passed along in an autosomal dominant pattern, meaning that you only need one copy of the mutated gene to end up having the disease condition. So that means a child will have a 50% of chance of inheriting that mutation from an affected parent. That's as opposed to a recessive mutation, which has a 25% chance of occurring in a child, assuming that the spouse is not affected. So it's very important to offer genetic counseling both before and after genetic testing, because there's a lot of psychosocial implications, family planning, and then access to different diagnostic testing and treatment strategies that have to be available. And also it's important to be able to determine if other family members are at risk, or is this disease going to be penetrant in all family members or not, et cetera. So there's different types of genetic testing that can be done. There's single gene panels or single gene testing, which is only really done if you know that VCP is the mutation that you're dealing with in the family. So maybe another family member has already been diagnosed, and then you can do targeted gene testing just for that gene. But as we mentioned, there are several other genes that can cause multisystem proteinopathy. Those are included in the dark box on the right. So the different genes that can be seen are HNRNP A2B1, HNRNP A1, sequestosome 1, matrin 3, TIA1, optineurin, annexin 11, and profilin 1. And so these are all very rare, versus VCP is seen in 50% of MSP patients, and these are all in much smaller percentages. But a lot of them can present in a clinically indistinguishable way as VCP MSP. So like I said, we'll be referring to VCP throughout tonight's talk, but the other genes are treated similarly. So a multi-gene panel would include VCP and potentially several other genes that can cause a certain phenotype. So for example, an ALS gene panel would include different mutations that could cause ALS, as well as VCP. Same with certain muscular dystrophy panels. And so a lot of the gene panels have more recently added the VCP gene. So if a patient hasn't had recent genetic testing, the doctor should make sure that they look over exactly which genes were tested in the previous panels. Even 5 years ago, VCP may not have been on the panel. Now, the tricky thing is when you do genetic testing and then you end up with these variants of uncertain significance or unknown significance, VUS. So every single person has variations in their genes from one person to the next. That makes every person an individual. But most of these variations are not necessarily pathogenic or disease causing. And so if it's a VUS, that means it's not pathogenic as far as we know. But that's not to say that it could be found to be pathogenic with further discovery of other people with this condition if they have the same symptoms. So anyway, this is something that physicians have to interpret with caution. Next slide. Next slide. Oh, okay, got it. All right, so myopathy is the first phenotype we're going to talk about. This is the most common phenotype that we see with VCP MSP. It occurs in 90% of patients. So myopathy causes muscle weakness. So initially, this will present with weakness in the proximal muscles, which means muscles that are close to the torso, close to the shoulders and the hips. And so patients may have trouble getting up from a chair, walking up or down stairs. They may have trouble lifting the arms above their head, versus the hands and feet may be preserved to a greater degree, or they may be affected as well, either early on or later on, because the presentation is quite variable. In general, the disease does progress slowly over the course of years, and severity can vary from one person to the next. Other symptoms that can be seen if there is distal weakness, you may have foot drop, so it's difficult to flex the ankle with the foot upwards. And then scapular winging is something that you see in the rightmost picture on this slide. This is a 40-year-old man with VCP, or 40 at the time of this picture. And scapular winging happens when there's weakness of the muscles that anchor the shoulder blades down. And so that's why they start to protrude. And so on him, it's kind of asymmetric protrusion. And asymmetric involvement of muscles can happen in about 20% of cases. The man on the left two images is a 66-year-old man with VCP. And you can see that there's some atrophy of his shoulder muscles, the deltoid, as well as the trapezius kind of above the shoulder, and weakness of shoulder abduction, being able to lift the arm away from the body. On the middle picture, you can see again that wasting of the shoulder blade area, the trapezius and the deltoid here. You can also see that there's thinning of his forearm and the pectoralis muscles on the chest. Typically we will not see facial muscle weakness, but you can see weakness of respiratory muscles with time as well. There are other hereditary muscle conditions that can present similarly, and some of those include limb girdle muscular dystrophy. That's one of the more common ones. So it's important to be able to have thorough testing with a neuromuscular specialist if possible, and the genetic testing as well will help distinguish those. Diagnosis, of course, the genetic testing is the only conclusive test, but there are several other tests that may be supportive and helpful to lead you towards the diagnosis of a myopathy before one may realize that this is a genetic condition or VCP. So the creatinine kinase is one of the first blood tests that we always check when we're suspecting a myopathy or muscle inflammation. It's a blood test enzyme that tends to reflect muscle breakdown, and it can be normal to mildly elevated in VCP. There are some other myositis conditions that can have extreme elevations of CK, and that may lead us away from a diagnosis of this type of myopathy. A nerve connection study or electromyography, these are electrical tests that we use in the neuromuscular clinic to assess the status of the nerves and the muscles and see if there's neuropathy, myopathy, motor neuron disease or ALS. We may be able to see mixed features in someone with VCP MSP, and that'll help us sort of tease apart whether nerves or muscles are involved and to what degree. A muscle MRI is something that's been more popular in the last 10 years or so, which helps us see things that are not visible to the naked eye. We may be able to see that a thigh muscle is a little bit atrophied, for example, but may not be able to see the degree of muscle loss, because if there's fatty tissue replacement of muscle, it may have the same bulk as it did before. But with an MRI, you can really see that some of that muscle was replaced with fatty tissue. For example, in VCP, there's something called fat pockets that you may see in the leg muscles, where there's a piece of muscle that's been replaced with fat, but around it there's normal muscle tissue, and that's another characteristic finding. And then finally, a muscle biopsy is another very important test for VCP and inclusion body myopathy in general, because it looks quite distinct from other types of myopathy. There's different pathological features that you might see, especially rimmed vacuoles, which are fluid-filled spaces with little protein deposits around the rim, variation in fiber size of the muscle fibers, and different protein inclusions. So again, if the genetic mutation's already been found, you don't need to do most of these things, but this is usually done on the way figuring out what type of myopathy is going on. Next slide. Okay, so unfortunately, there is no disease-modifying therapy for the myopathy seen in VCP. However, there are various supportive management strategies. So physical therapy and occupational therapy are really paramount for supporting muscle function, endurance, range of motion, and strength. So PT can help with guidance on what appropriate and safe exercises are, as well as what assisted devices may be appropriate, and if there's home adaptations that should be considered. So different mechanical aids that may be considered are canes or walkers, wheelchairs. There may be modifications in your car that need to be done, shower or toilet chairs, lift seats on top of the toilet if there's weakness of hip flexors, so it's hard to stand up from a lower chair, lift chair to go up the stairs, transfer aids, grab bars, and the list goes on. So physical therapists, occupational therapists will be able to help with that. OT is a little bit more focused on fine motor movements with the hands, and can also prescribe different assisted devices and exercises. Speech language pathology, which is the preferred term over speech therapy, is important if patients have involvement of the bulbar muscles, which are muscles that are important for speaking and swallowing. And they can prescribe different therapies for speech enunciation, or if there is speech loss, for different assistive communication devices like tablets or alphabet boards and things like that. If there's swallowing involvement, then there are diagnostic tests like clinical swallow tests, barium swallows that can be important for assessing that as well. Respiratory therapy is also important if there's lung involvement, and we'll talk about that in a lot more detail at the end. So at baseline, when VCP has been established as the mutation at hand, a patient should have a neurologic evaluation right away. And then they should follow with a neurologist every 6 months to a year if they have myopathy. If they have weakness that's progressing more rapidly, then they should see their neurologist more often. A multidisciplinary team approach is also really important, which includes all these different supportive therapies that mentioned on the left. And those should be done every 6 months to a year. Next slide. Okay, Paget's disease of the bone is something that occurs from abnormal bone formation and remodeling due to increase in bone resorption and disorganized bone formation. This occurs in 40% of VCP MSP. It can involve any bones in the body, but the ones most commonly affected are the spine, pelvis, skull, and legs. And the bones that are affected can become enlarged and thickened, sclerotic, as we say, deformed. Like on the bottom picture on the left, you can see that the tibia and fibula are sort of bowing out. And this can cause a lot of pain in that bone that's involved, can cause fractures, osteoarthritis. If the little inner ear bones are affected, that can cause deafness. And depending, again, on which bones are affected, even nerves can be compressed. The best test to diagnose this condition is a radionuclide bone scan, where a little radioactive material is injected as a contrast dye, and a bone scan is done, as you see on the top right picture. And that can detect different bones that are involved. So the left skeleton here is a front view of a person, and then the right side is his back view. And you can see in this patient with Paget's that his femur is involved, a bit of his pelvis, shoulder blade on the left side, a bit of the skull. And then on the back view, you can see his spine, the thoracic vertebrae, and even his right heel are also involved. So this is kind of extensive case of Paget's. An X-ray is an easier, quicker test that can be done for focal bone pain. So you don't have to do a radionuclide bone scan every single time a new bone is involved, but an X-ray can be done to assess for that. So on the bottom right, you see this is a woman with Paget's with VCP, and her T10 vertebrae in the middle of the back is kind of thickened and looks denser on the X-ray image, and that is a bone that's affected by Paget's. There's also blood tests, different biochemical markers that can reflect increased bone turnover. The most useful test is the serum alkaline phosphatase, or ALK-Phos, or ALP. That's typically elevated when there's active Paget's disease, but it's not the most sensitive test. And just an ALK-Phos elevation by itself doesn't mean that there's a bone disease, because it can be elevated with liver problems or other organs that are involved. So it has to be a supportive test only. There's several other blood tests that can be done, but they don't have any clear diagnostic advantage over ALK-Phos. And so ALK-Phos is the one of choice. And also, interestingly, if someone has a diagnosis of VCP myopathy, for example, and there's no signs, no symptoms of bone pain or fractures, but you check an ALK-Phos, you may incidentally find that it's elevated, which may reflect that there's some subclinical Paget's disease going on. Next slide. Okay, so treatment. This one does have disease-modifying therapy, which is used with bisphosphonates. These are the same drugs that are used in osteoporosis, and they can be helpful for bone pain. Also, if a patient has vitamin D deficiency, this should also be treated early on before using bisphosphonates. About 10% of patients with Paget's do require orthopedic surgeries. That could be for fracture repairs, hip or knee arthroplasty or spinal surgery. We don't know exactly if prophylactic treatment with bisphosphonates is necessary for people with Paget's or with people with VCP MSP, but there is a study that's being done to determine if that's going to be a useful strategy. At the time of VCP diagnosis, you should do a baseline bone scan, even if there's no symptoms of bone pain. If bone pain develops, then you should do a bone scan at that time as well. And then you can follow with a serum alk-phos every 6 to 12 months as well. Next slide. All right, moving on to FTD. This is a decline in cognitive function because of degeneration of frontal lobes and temporal lobes, which are important for language as well as executive function and personality and behavior. This occurs in about 30% of patients. So the two major variants that you'll see are behavioral variants or primary progressive aphasia. The latter is more language predominant. The behavioral changes you'll see are apathy, disinhibition. So patients will have more compulsive behaviors, including overeating or doing things that might be dangerous. Loss of empathy is another one. Language deficits may start with word finding difficulties, loss of word comprehension, and diminished fluency. Signs and symptoms are very variable from one person to the next, but they do tend to progress over time, over the course of years. The diagnosis really comes from clinical history, not only from the patient, but also the caregivers and family members. The patients themselves may not have as much insight depending on how far along they are in their condition. And then other initial screening tools that we use are bedside cognitive tools like the MoCA, the Montreal Cognitive Assessment, which has different exercises like naming different animals, drawing a clock, connecting dots on a page, counting backwards, and things like that. And then the Neuropsychiatric Inventory Questionnaire is a structured informant-based tool that also can help tell us about behavioral changes. A brain MRI also can help confirm the diagnosis when you see atrophy of those frontal and temporal lobes, like you'll see in the top right picture here, which is an MRI cut this way. And you see the brain should be nice and full out towards the center, out towards the periphery of the skull. And you see that there's black fluid spaces that are kind of overly prominent here. An FDG PET is another imaging technique that can be done, which doesn't have to be done for diagnosis, but it can help show you that there's reduced metabolism in those same frontal and temporal lobes as well. And then these patients should also be referred to a memory disorder specialist and possibly neuropsychiatric testing. Next slide. Again, for this one, there is no disease-modifying therapy, but there are different lifestyle modifications and supportive strategies that can help. One of those is an active lifestyle, which has been shown to slow functional decline in FTD. And so it's important to encourage regular exercise, as well as proper nutrition and stress management. Patients also benefit from a daily routine with activities that the patient enjoys. If the caregivers can help them avoid triggers for high-risk behaviors, so make sure the car keys, money, sweets, or other triggers for them are out of sight and or not accessible to them. And also redirecting behavior is also helpful. It's also very important to have proper caregiver support and education because they're at risk for higher burnout. Speech language pathology can help with communication skills. It's important to initiate early on while they're still able to understand and participate more effectively. And also an augmented alternative communication device or AAC device, things like a tablet with text to voice, for example, can be a great way of compensating for those language changes. Some patients with different behavioral symptoms may benefit from antidepressants or antipsychotics, but it'll depend on each individual patient. One thing to avoid is the drugs that are specifically for Alzheimer's dementia, such as donepezil or Aricept is one of the most common ones. And then you may wonder about the newly approved drug from Biogen, aducanumab, but these have either not been studied in FTD or have been proven to be ineffective in FTD. So at baseline, these patients should have the MoCA or NPIQ test done and an annual neurological assessment. And then, of course, be sure to report any symptoms to your doctor. Next slide. Okay, ALS, also sometimes we call it motor neuron disease, but ALS is a specific type of motor neuron disease. This is a neurodegenerative condition that affects the neurons or nerve cells that control voluntary muscle movement. That can be in the arms, the legs, the torso, respiratory muscles, and the bulbar muscles for speaking and swallowing. Typically, the weakness will occur in different areas of the body, and it will be associated with a change in reflexes. When we tap you with a reflex hammer, usually the reflexes will be increased or hyperreflexic, but sometimes, in some cases, the patient's reflexes can be reduced, actually. There's also wasting away of muscle tissue or atrophy. You'll see in the picture on the right here, the patient has atrophy of the muscles between the thumb and the finger. That's a common place for atrophy to start in patients who have upper limb involvements. Fasciculations are brief little muscle contractions that look like flickers of the muscle tissue under the skin. Now, fasciculations are something that happen in pretty much everybody, even without any muscle or nerve disease. Most people get them at some point. Some people get more than others. But if the fasciculations are associated with muscle weakness or atrophy, that's when we start to be a little bit more concerned. But fasciculations in and of themselves can be benign. Bulbar weakness can include slurred speech, and there's a very characteristic type of spastic speech that ALS patients have that's different from slurred speech from other conditions. And then we are actually trained to recognize that. It sounds different to us. And then also they can have difficulty with chewing or swallowing. They may have to modify the consistency of their food, may have to have chopped up small pieces, softer foods or pureed foods. May have trouble coughing up on liquids or solids. These are important things to notify us about as well. Respiratory muscle weakness can present with shortness of breath, difficulty laying flat. And then weight loss can occur not only because of the wasting of muscle tissue, decreased appetite, and also trouble with swallowing, and inability to maintain enough caloric intake. Diagnosis will come mainly from the clinical exam, where you're going to see involvement of the upper and lower motor neurons. That means motor neurons from the central and peripheral nervous system, the brain and spinal cord versus the nerves towards the muscles. Those are how we distinguish them. And then a nerve conduction study, EMG, is really important because that can look very characteristic with motor neuron disease. It's also important to rule out other mimics of ALS because ALS can look like other muscle, nerve, brain, or spinal cord conditions to a certain extent. So other blood tests and imaging may be necessary to rule those out as well. If a patient has trouble with swallowing, a swallow study is very important to assess that, and pulmonary function tests are important to assess the lung capacity and lung force. Next slide. There are a couple disease-modifying therapies that are FDA approved for ALS. The first one is called Riluzole, which came out in the 1990s, and the second one is Edaravone, which came out in 2017. And now there's an oral form that was IV, and now it's also oral. These drugs are don't always have to be prescribed to patients with ALS. It's based on provider and patient preference, especially in the VCP situation where there's no data to say if it's as effective in VCP ALS as in non-VCP ALS. So that's going to be a discussion with the doctor and the patient. Supportive managements are basically similar to the ones I showed you in the myopathy slide, where PT, OT, and SLP are major cornerstones for treatment, as well as RT. RT is going to be helpful when they need help with pulmonary hygiene, cough assist device, and suction if they have too much phlegm that's collecting, and BiPAP, which helps with ventilating the lungs as well. A social worker is another important part of that multidisciplinary team approach. In ALS, we recommend a multidisciplinary team visit every 3 months. And at baseline, if you notice that your patient who maybe had myopathy for many years suddenly is having a rapid decline and a change, suddenly is developing hyperreflexia, those are signs that maybe ALS could be developing and an EMG should be done, and they should see a neuromuscular specialist. Okay. Charcot-Marie-Tooth disease is a specific type of hereditary motor and sensory neuropathy, and there's hundreds of different genes that are associated with CMT. VCP is now recognized to also cause what we call CMT2Y. This affects the axons of the nerves rather than the insulating sheath around them, and that's how we break down different CMT subtypes. This will cause numbness and weakness and muscle atrophy, especially in distal muscles, meaning the feet and the hands, because the length of the nerves predisposes those nerves to more damage. The longest nerves, especially the toes and feet, are most vulnerable. So this also means that you'll lose your ankle reflexes before you lose your knee reflexes, for example. And sometimes you can have osseous bone changes. So you might have hammering of the toes where they sort of curl up, and the foot actually might become high arched. And that's because of unopposed action of those flexor tendons when you have this very chronic over many years weakness. Diagnosis depends on clinical exam as well as nerve conduction study and EMG, and the genetic testing, of course. There is no disease modifying therapy again here, but supportive management with PT, OT, and assisted devices is important. And some patients also do require surgical correction of any foot deformities. So for surveillance, there should be a baseline nerve conduction study EMG for all VCP patients. Okay. All right, Parkinson's disease. So this is a progressive central nervous system predominantly disorder where there's degeneration of neurons in the brain that produce dopamine, and that causes movement disorders. This occurs in about 4% of patients with VCP. There's very diverse clinical features that you can see, but one of the major hallmarks is a hypokinetic movement disorder. So there's bradykinesia, which means slowness of movement. So patients may, take a lot longer to move their arm out or move their leg or take a step. They may have shuffling gait. They can't turn fluidly when they're walking. They may have freezing of their gait as well, where they kind of stop suddenly. They also may have non-motor movements, non-motor features, such as REM sleep behavior disorder, disorder of being able to smell properly, behavioral changes or cognitive changes, and also autonomic dysfunction. The autonomic nervous system is responsible for regulating things that are not under voluntary control, including blood pressure regulation, bowel and bladder function, and sexual function. So patients may have what we call orthostatic hypotension. When they stand up, their blood pressure drops because their body can't regulate it as well. So they may have dizziness from that. Diagnosis comes from the clinical exam by the neurologist. So you'll see slowness of movements. They may also have a tremor, or what we call a pill rolling tremor. So it looks like they're rolling a pill because of that, the way their fingers are moving, and postural instability where they're kind of off balance. Another test that's very helpful is the dopamine transporter scan, or the DAT scan. And that shows a decreased dopamine uptake in these deep structures of the brain called the nigrostriatum, or the caudate and putamen. Those form a comma-like structure you'll see on letter A on the top right. So on letter A, that's a normal brain uptake of dopamine in those deep brain structures. On B, you'll see a patient with Parkinson's, and they have really decreased uptake of the dopamine. And so especially in the putamen, less so the caudate on the top side of it. And it's a little bit asymmetric, which is not atypical. These patients can respond really well symptomatically to dopamine replacement with carbidopa, levodopa, and there's several other dopaminergic drugs that are also on the market that can also be helpful. These don't reverse brain damage or slow the disease down per se, but they do help with symptoms significantly in a lot of patients. At baseline, these patients should always have MDS, Movement Disorder Society, Unified Parkinson's Disease Rating Scale, so the UPDRS. This is a scale that assesses how much tremor do they have, how much slowness, how is their gait, etc. The problem is it's not really clear how much other conditions like myopathy or Paget's can really affect those numbers. And so those may confound the score actually, because it's not related to Parkinson's itself. Okay, next slide. Cardiomyopathy is when there's a disorder of the heart muscle tissue, and that makes it harder for the heart to pump out blood to other parts of the body. The frequency of this is uncertain, and it's seen in case series only, but it has been published with regards to VCP. Clinical features, it may be a silent thing where you don't notice any symptoms of it, and it may just be seen with imaging. But if it gets severe enough, they may start to have shortness of breath with exertion and signs of heart failure, swelling of the legs, for example. Diagnosis is preferably made with a cardiac MRI, which has a more high definition picture of the heart structures. And an echocardiogram can also be done, but it's not as good in situations of cardiomyopathy. You can see on the right side, the top two pictures are an echocardiogram, and the bottom two pictures are the cardiac MRI, where it's a much sharper image of the different ventricles and the aorta, the septum between the different ventricles with the MRI version. With treatment, there are disease-modifying drugs. There's different medications that help with cardiac remodeling. They're actually the same medications that we use for a lot of hypertension patients. So those are like ACE inhibitors, beta blockers, mineralocorticoid receptor antagonists, very commonly used drugs, and those help with non-ischemic cardiomyopathy. So a cardiomyopathy that doesn't happen from a heart attack, basically. So devices and surgery are reserved for people with very severe disease. So those may be defibrillators, an LVAD, which is a left ventricular assist device, or a heart transplant. But data on this in VCP is kind of sparse. At baseline, a cardiac MRI should be done at the time of diagnosis, and this should be repeated every 2 years if abnormal or if symptoms come up. Slide. Okay, respiratory dysfunction can happen from either the myopathy or the ALS, more likely, or even from a brain disorder like the FTD. This is probably underdiagnosed and understudied in VCP, but it may occur in about 40 to 50% of patients. So different clinical features you may see are recurrent pneumonia, which is a lower respiratory tract infection where there's difficulty clearing the airways and should be treated with antibiotics. A weak cough means that there's difficulty clearing the phlegm. Aspiration is when you swallow food down the wrong pipe. So instead of going down your esophagus, it might go down your windpipe into your lungs, and that can trap bacteria and cause pneumonia. Also, sleep disordered breathing can occur, which may make it difficult to lay flat at night, may dysregulate your breathing patterns at night, and may cause sleep apnea. And that may also in turn make you more fatigued the next day. You don't have restful sleep. So this is another thing that needs to be managed. And then respiratory failure is when there's an inability to breathe on your own or an inadequate ability. Okay, next slide. All right, several different tests that can be done. One of the most readily available and simple tests is with a blood test called serum bicarbonate. And this is actually a very reliable measure of chronic renal compensation, kidney compensation for chronic retention of carbon dioxide. A pulmonary function test is really important. We like to do these right away for our myopathy and ALS patients. This has several different sub-aspects that can be measured in terms of the capacity of the lungs to hold in air, the force that someone can exert when blowing out into a valve. One of the most important ones we use is the forced vital capacity, or the FVC. There are specific cutoffs that we use. For example, if your FVC is less than about 50%, that's when we may start to initiate a BiPAP mask, for example. A sleep study is also important, either in a lab or a limited version at your house, to detect sleep disordered breathing. Respiratory therapy is vital to help with pulmonary hygiene and proper ventilation. There's different devices that are useful. For example, a cough assist, which is a mask to help you clear out your phlegm in your airways. And then the non-invasive positive pressure ventilation, or BiPAP. BiPAP stands for bidirectional positive airway pressure. So when you wear the mask, whether it's the full mask over the nose and mouth, or the triangular one over your nose, or the nasal pillows that are just over your nostrils, that helps blow air out and in. It's not oxygen replacement, it's ventilation. And then the other important thing is vaccinations. It's important not only for the patient, but also for the family members and caregivers to be up to date on vaccinations to help get ahead of any infections that could occur. And you want to treat any infections early and aggressively. At baseline, patients should have all three of these diagnostic tests done, and PFTs should be repeated annually, or sometimes even more often, especially with ALS patients. We might do them every 3 to 6 months. Next slide. I wanted to also mention urinary and anal incontinence. This has been reported in isolated cases. This can significantly affect your quality of life and affect your daily lifestyle, your routine, your ability to participate in social settings. Clinical features may include leakage, urgency, frequency, and retention. Diagnosis is really going to come from the symptoms that you report, and there's several other tests that your doctors can do by the urologist or the gastroenterologist, including a bladder scan, anal manometry, etc. Treatment depends on the type of incontinence that we're dealing with. A lot of myopathy and ALS patients may suffer from functional incontinence, which doesn't mean that they have a problem with their bladder itself, but it's because they have decreased ability to run to the bathroom because of weakness in their legs, for example, or they're wheelchair bound, and so they just can't get there in time. So in those cases, you can try to manage that with addressing issues of mobility, making sure they have a wheelchair that can get into the bathroom, helping with that accessibility, grab bars, lift toilet seats, scheduled voiding, so making sure that you go every 1 to 2 hours with the help of someone else versus waiting until you really have to go. And then there's other forms of incontinence as well, like stress incontinence, urge incontinence, where there may be leakage from, coughing or exercise or laughing and things like that. Other lifestyle modifications may be helpful, like how much do you drink before you go to bed, pads, pelvic floor therapy, and then there are different medications, devices, and surgeries for more severe cases that urologists and GI doctors can help with. These should be screened for with annual examinations through patient survey and then referred to the appropriate specialists. Next slide. Okay, and then patients always have a lot of interest about nutrition and supplements. So as a disclaimer, there have not been specific diets or supplements formally studied in VCP patients, but it would not be unreasonable to say that an anti-inflammatory diet could be recommended due to the high degree of oxidative stress that's seen in the pathophysiology of VCP MSP. So that would be a diet that's high in vegetables, fruits, whole grains, lean protein, fatty fish, low in foods that have artificial preservatives, pesticides, and things like that. You also could extrapolate for VCP that a Mediterranean diet could be helpful because it helps with dementia and cardiovascular disease. You also may theorize that because of the oxidative stress that occurs with VCP, supplements that help reduce oxidative stress may be helpful, like alpha lipoic acid or coenzyme Q10. However, we don't know that taking those supplements will help alter the course of the disease. So it may be helpful to discuss with a nutritionist or a dietitian as well. With regards to exercise, we do recommend low to moderate intensity exercise. It's important not to be totally sedentary because then you'll lose out on preserving that function, that strength, range of movement, and endurance. So you want to keep an active lifestyle as much as you can to preserve that independence and participation. PT and OT are recommended if there's any trouble with performing your activities of daily living, your mobility, or your transfers. And then we did mention some of those assisted devices earlier, which are also going to be important. Next slide. Okay, and then last but not least, mental health is also crucial for both patients and caregivers who are at higher risk for stress, depression, and anxiety. Not only because of having a disease and different symptoms that are affecting your quality of life, but also just the rare nature of the disease, the ultra rare nature. So that means that patients are predisposed to misdiagnosis, lots of different doctor's visits, carting around to different hospitals and medical centers, differing clinical opinions, lack of information, both for themselves and for their doctors, and then the lack of disease-modifying therapies for most of the different phenotypes that we talked about, the economic burden, not only for the cost of all the medical care, but also losing out on the ability to work, both for yourself or your caregivers, not being able to go to your job, and then the isolation. All of those things can compound upon the issues with mental health. So it's important to screen for the behavioral health signs and symptoms and refer to the appropriate providers for that. Treatment includes not only medications, but also therapeutic support to help manage and process the diagnosis, work towards your short and long-term goals for improving quality of life. There are peer and professional support groups that are available. And then it's important to work on reducing the risk of self-harm and validating feelings of fear, grief, and anger. So this should be screened for routinely with patient survey. Okay, next slide. All right, so we're at the conclusion now. Just to summarize what we talked about today, VCP MSP is rare or ultra rare and is very heterogeneous and very different multi-organ phenotypes that are seen not only from one patient to the next, but even within a family. And the severity and types of symptoms, clinical features that you see can vary a lot from one person to the next. Because of this, we have to have better awareness and management in the physician community because patients may be underdiagnosed. Our international multidisciplinary meeting that we had in April of last year helped us establish the standard of care recommendations that we talked about today, and that included expert opinions and literature review. Now, next, we need to develop an optimal clinical outcome assessment so that we can better assess patients with VCP MSP. Right now, if we're using the UPDRS for Parkinson's and the ALS-FRS, are we losing out on different aspects that really reflect the interplay of the different organ systems that are involved? So once we have a better clinical outcome survey, we can better monitor and manage patients, and then also use those for clinical trials in the future. So we do need future large-scale studies to actually figure out if there are disease-modifying therapies that we can target for VCP and the underlying subtypes. And not only for medications, but also for what exercise treatment programs are the best, or what diets are the best, and so on. All right. That's it. So these are the references that we used here. And I'll be happy to take any questions. We have some time. So if you want to unmute yourself, I'm happy to talk.
That was fabulous. It was so well done. I just feel so much more empowered to be able to ask good, insightful questions to my doctors. And I see now the importance of a multi-disciplinary team. That's been really beat into my head this week. And I think that's great. I hadn't really considered that before. Thank you.
I'm glad. Yeah, we have seen that the multidisciplinary team approach has been really helpful for patients with ALS, for example, but also with myopathy. And hopefully, we're hoping to establish a VCP clinic in UC Irvine at some point. So that would take in patients from different geographic regions who could get here. Maybe we would start with it quarterly, and then maybe we could even get specialists from a rheumatologist or an endocrinologist, for example, and a cardiologist, et cetera. So not only multidisciplinary in the sense of PT, OT, SLP, but maybe even other physician specialties too, down the line.
How is this information getting to our doctors?
Well, Allison has tried to publish these. So do you have any input on that?
Well, so all the doctors that we know about, we've sent it to via email. But also, Virginia, have I sent you these?
Yeah, those are great.
Virginia, I'm gonna, if I hadn't sent them to you yet, I'm gonna mail them to you tonight or tomorrow morning. And you can just take this and hand it to your doctor and say, hey, here's published guidelines on how to take care of me. And Amy, or does somebody want to give a testimony of how it's worked?
Absolutely. I think you may have not been on, Virginia, when I talked about this at happy hour, but my cousin was having a mastectomy because she had breast cancer, and I wanted to, she has VCP disease also, but she's kind of a bury her head in the sand person and doesn't really know what to talk to the doctor about and things like that. So she wanted me to go with her, and I was talking to the anesthesiologist about it's really important that she doesn't have certain paralytics during anesthesia. And I had one of those business cards in my purse, and I gave that to the anesthesiologist, and he read it, and that card followed her from pre-op all the way to her room after the surgery. And when they were bringing her in after surgery, after she was out of the recovery room, the nurse was giving a report to the nurse on the floor, and she said, I've never seen this before, but this card has this QR code on the back, and it has this document all about this disease that she has. It's really cool. And I was like, yeah, it is really cool. So they're wonderful.
I just had an appointment with a brand new primary doctor. Now I'm like Pence with a fly on my head. It's a brand new doctor, so I called them in advance and told her to do research on VCP, because otherwise she wouldn't know, what to do. And luckily she had read up on it, so she seemed to know a little bit about it. I don't know what she found. I just sent her to Cure VCP. But yeah, if that card has its links on it, or just
It's a QR code that people, they can scan with their cell phone and it'll take them directly to the document.
Cool. Okay, thank you.
Very cool.
I have a question about that QR code. So does that just bring up the standard of care that, or does it give more of a doctorese? I mean, is that like a doctor level? And then, because I know I've seen, it is doctor level? Okay, thank you.
Well, so this is what I've learned is that as a patient, you go to the doctor and you tell them you have this crazy disease, right? They've never heard of it. And so if you say, hey, here's the website, you know, the patient advocacy organization, not as valid. But if it's been published in a medical journal and it's been published by people from all around the world from these prestigious institutions, they'll listen to that. Right, Dr. Korb?
Yeah, that always helps. I think we like to see publications to know, how valid are these different findings. And another thing to mention is that, Cure VCP has a good presence at different academic conferences for neurology throughout the year. So there are posters, there's presentations, and with all these different publications that are out there, anyone who's up to date with those things in the medical field will be able to learn about this disease more.
Yeah, I did want to mention Dr. Korb presented a poster at the MDA clinic or the MDA conference, the national conference. She had a big poster. So whenever you have a poster at a medical conference that all the leading doctors go to, it really is good circulation. The publication has been accessed 2,500 times.
Wow,
Mhm.
that's great.
So,
I have a question. You
so
talked
that's
about-
more than known patients in the world. So
Allison, can you send some of those to me too? It's Paul.
yeah, I sure will.
Great, thank you. So I actually have a new internist and he's curious about it.
Mhm.
Thanks.
You talked about future studies and them being large scale. How do you plan to get a large scale study on a disease that is so rare? What is the plan and what do you consider large scale?
I guess it would be a relative large, but hopefully a multi-center. So you would have to have collaboration between different academic hospitals throughout the country, or even different countries too, which I think would be possible. And then also if we could find a way to do remote assessments of patients. So some things that could be patient recorded surveys, Zoom interviews and Zoom clinical exams, so that even if accessibility or access to a center, if you say you live 8 hours to the nearest academic center, you could still participate in the study. So we're looking into things like that. Dr. Virginia Kimonis is one example who's looking into that.
Manisha, I did want to mention that a lot of the patients on here today are participating in Lindsay's remote study.
In Nationwide?
Yeah, and Lindsay was a collaborator on this project.
Oh, great. Yeah.
Mhm.
Yeah. And that has some remote assessments too, right?
Mhm. It is. It's validating all the remote assessments that are used in limb-girdle and Duchenne's muscular dystrophy. So, and also spirometry.
Mm-hmm. Yeah, it's great. If you can do the spirometry at home, that also cuts back on the visits you have to make and the drives and everything. Any other questions? Oh, Nupur has a question.
Well, I was going to
Hi.
have a little comment. Hi there, everybody. Nice to have Manisha kind of bringing all the standard of care work together in one place. I was going to say that in terms of future studies, we have ongoing collaborations I think are going to be great springboards. So I come from the FTD space, and we have a 19-site consortium through North America. And so we are, from the FTD vantage point, we have done some remote assessments, especially kind of brought forth by the COVID pandemic. But I think there'll be opportunity as y'all come to, I'm at WashU in St. Louis. As you come to St. Louis, we'll be able to kind of tell you more about our programs here. And not that we can't have things very much tailored for VCP, but there's certainly other networks that we can start plugging into and kind of get the story moving forward. Just wanted to jump in and throw that into the ring as well.
Thank you so much. That's awesome.
there any indication of, or maybe this is not something that's usually put into a standard of care, but how long does this last? I mean, how long can I expect to live? Is the bottom line question.
Oh, I think that's so variable because it depends what phenotypes you have and what other comorbidities you might have. So say someone with an ALS phenotype versus someone with a myopathy phenotype, those are going to be very different prognosis. For example, it could be a few years versus decades. It's just so variable based on that. It also depends on how much respiratory or bulbar muscle involvement you have, how much dementia there may be. Those are the things that really affect prognosis and lifespan. So the respiratory status and speaking and swallowing.
So your doctor would know best, I guess?
Yeah, because it's such a wide variation from one person to the next. But you should ask your doctor, exactly.
It's a real question, and I just had a meeting with my doctor today, and that's a decision we're making at this moment, and she has no guidelines at all, and all I can tell her is how badly I feel. So I was just wondering if there's anything out there that talks about that. How long?
Yeah, I mean, again, it's so variable, and I would say your neurologist who's managing different aspects of the disease should be able to make some comment on it. Although the other problem is people's trajectories are not always linear. So even with ALS, for example, which I see a lot of, while they may be kind of like a slow progression like this, suddenly it might tank, or it may be really fast decline for a while, and then it may just sort of stay the same for a long time. So again, it's sort of hard to make solid predictions based on that. But things that we use the most are the pulmonary function tests and how many other comorbidities. Like, does someone have heart disease too, for example? That's also going to play into it.
Thank you.
Other questions?
I did want to put a plug in for Dr. Gishal. She was a collaborator on this project. She was integral to developing the FTD portion of this.
Definitely.
I don't think we would have been able to publish with it without her contribution. So thank you, Dr. Gishal.
Yeah.
Well, thank you. It was a fabulous group that y'all brought together, and under your leadership and kind of gentle and persistence nudging, I think we finally got the job done, right? So just kind of never losing sight of what we need to get done.
Yeah, thank you so much.
Yeah.
All right, Allison, should we wrap up if everyone's had their questions answered? And I'm always available if anyone wants to email me. Allison has my info.
Yes. Thank you, everyone. Thank you so much for joining in. And we're not done. Care is always changing, and there's more to do. But thank you so much, Manisha. Appreciate it.
Thank you so much. Thanks for listening, everyone. Have a good night.
Thank you.